Hello and welcome to eviCore Healthcare's educational webinar series. My name is Bill Cornelius and I'm the Insights webinar host today. eviCore is a company that empowers the improvement of care by connecting patients, providers, and health plans with intelligent evidence-based solutions to enable better outcomes. If you would like to learn more about eviCore and how we enable better outcomes for patients, providers, and health plans, please reach out to sales@evicore.com for more information. Throughout 2021, eviCore will host free educational webinars that include guest speakers as well as eviCore subject matter experts to discuss today's most pressing healthcare topics. Stay tuned for our future webinars with new topics presented each month. We hope that you'll all attend. And now it is my privilege to introduce you to the panel today. Our Senior Medical Director of Gastroenterology, Dr. Sheldon Scheinert, and our clinical panelists, Dr. Joseph Weiss, Dr. Jaya Agrawal, and Dr. Tahid Ghazi. We're excited to share an in-depth discussion about the challenges in understanding the potential risks of low-yield gastroenterology procedures and how eviCore helps gastroenterologists stay abreast of the recurrent modifications to the clinical literature and guidelines. This presentation will be recorded and it will be available on demand located on the Insights page at evicore.com. Take it away, Dr. Scheinert.
Thanks, Bill. Welcome, everyone. I am Sheldon Scheinert, and I am Senior Medical Director in charge of eviCore's gastroenterology program. I have been with eviCore for 6 years now. I practiced in Florida about 30 years prior to joining. Thank you all very much for attending this webinar. With me today are 3 of eviCore's GI staff. We have Dr. Joseph Weiss, who comes to us from California. He is a clinical professor of medicine at UC San Diego and is the author of several highly acclaimed books on the topics of preventive health, nutrition, and other GI issues. We have Dr. Jaya Agrawal, who obtained her undergraduate and medical degrees at Brown University and completed her training at Brigham and Women's Hospital at Harvard, and has had several leadership roles, including president of the Massachusetts Gastroenterology Association, president of the Hampshire Medical Society, and was recently named Community Clinician of the Year by the Massachusetts Medical Society. And we have Dr. Tahid Ghazi, who trained at Tufts University in Boston with special training in more advanced gastroenterologic procedures. As an aside, our staff includes a total of 12 board-certified gastroenterologists. So again, welcome everybody. The talk today is designed to be an introduction to eviCore's GI program, which was initiated and went live in December of 2019, and currently involves EGD and capsule endoscopy. Next slide, please. So we started looking at gastroenterology about 3 years ago with a view toward assessing whether endoscopy should be a procedure in which utilization management would be of benefit. And if so, how would it be structured and what would it look like? This was driven by the fact that there are about 7 million EGDs performed in the US every year. As gastroenterologists, we all understand the crucial role that EGD plays in the diagnosis and treatment of a host of ailments and complaints. But as we looked at the data in the literature, we discovered that there were several areas of significant overutilization. For example, studies have demonstrated that about 38% of EGDs are discordant with evidence-based guidelines. So where and why does this occur? Next slide, please. We see that high on the list is Barrett's esophagus, And this is true in terms of both initial screening and follow-up. Barrett's means that there are cell changes of metaplasia, but not necessarily dysplasia, and it is dysplastic cells that enhance the risk for malignancy. And so whether there is dysplasia or not, very importantly informs the frequency of follow-up. Other areas of overutilization are dyspepsia, when there has been no testing for H. pylori, or an attempt at conservative management, or reflux, where again, there has been no serious attempt at an empiric trial despite GI Society guidelines that specifically discuss this. We also commonly see requests for serial EGDs for patients with GERD who have been screened one or more times in the past for Barrett's and already found not to have it. So why do some endoscopists perform a low-yield procedure? Next slide, please. Several correlates have been identified in the literature. For example, in one study, 30% of GIs in California cited medical legal concerns as the chief reason. Interestingly, it has been suggested in the literature that the primary predictor for the use of EGD in a low-yield situation was previous identification of having been a defendant in a malpractice suit. Endoscopists may fear missing dysplasia, for example, in a Barrett's case. What else impacts overutilization? Well, patients and providers often anticipate a serial cancer screening approach in situations where it is not appropriate and may view no screening or just once in a lifetime screening as inadequate, even though that is what is backed by the evidence. This is often based on an inflated estimate of the risk of cancer and the anxiety that goes along with that. And this often overrules what the evidence tells us we should be doing. Financial incentives may play a role in some cases. For example, patients enrolled in a VA system are much more likely to be followed according to guidelines for Barrett's, for example, than those with private insurance with a different reimbursement structure, particularly fee-for-service. Also, not everyone is familiar with guidelines. Medical literature is updated so frequently that it is often hard for subspecialists to keep up. Sometimes doctors simply disagree with guidelines. Sometimes it's a function of inertia. Some doctors are reluctant to change practices that they have had for many years that seem to work for them, despite the changing science. But these low-yield procedures can come with a cost. Next slide, please. So we need to recognize that EGDs are not risk-free. The risks are low, but they are present and sometimes have serious consequences. Overall, the complication rate from EGD hovers between 1.3 to 2.4 per thousand procedures, with cardiopulmonary complications the most common, about 60%. These are mostly minor, but some are major and range from significant desaturation to aspiration, respiratory arrest, stroke, shock, and very rarely death. Perforations during a diagnostic EGD are rare, but they occur in patients, for example, with a Zenker's diverticulum, where suddenly the endoscopist finds themselves in a blind loop or an unexpected stricture. Mallory-Weiss tears at the junction of the esophagus and stomach also occur in about 0.5% of diagnostic EGDs. Most are minor, but some require intervention. The point here is that there are about 7 million EGDs a year, which means that there is the potential for thousands of complications every year. And that begs the question that if the performance of a low-yield procedure is being driven by fear of malpractice or anxiety, are we actually protecting the patient and acting in the patient's best interest by performing it? We're not going to go into a discussion, of course, about malpractice and defensive medicine. That's not our focus here. But it's just to raise awareness of how these issues and others may impact some of our decisions, and that these decisions are not cost-free and are sometimes seen with unintended downstream consequences. Next slide, please. So this led us to come up with documents where we incorporated the latest literature and the latest society-endorsed recommendations into a guideline, which is then used to help determine the appropriateness of a procedure. This is what we use to adjudicate a request for an EGD. This is an example of what we look at. We get a request and we see if the information provided meets the criteria established by the various GI societies to justify an EGD. This guideline then serves as the basis of adjudication. It's what we use every day, and it's available to everyone. It is not hidden. Next slide. So using these guidelines, pathways are constructed and nurses are educated to reflect what the guideline tells us. But pathways and nurses can only approve a request. They can never deny or find a request non-approvable. The only person who can do that is one of our board-certified gastroenterologists when they review the case. But anywhere along that pathway, before it gets to the gastroenterologist, if the appropriate information is provided and the request meets criteria based on what we saw in that guideline a second ago, it's approved and we're done. So we can see by the type of information that we look at, the type of information you send us, that it becomes very important that the proper information is provided. This does not mean providing every possible record on the patient. Sometimes we get 400 pages of notes. If the request is for an EGD, it is counterproductive for your patient to provide a whole bunch of information about, for example, an unrelated back problem. When that is done, the relevant information can be lost in a mass of irrelevancies. What is important is to provide the clinical data that relates to the study being requested. The guidelines are out there. You can understand what we are looking for, and you can direct that appropriate notes and clinical information relevant to the specific request, in this case, an EGD, are provided. That gets you in and gets you on. Should there be a disagreement, then of course, there are mechanisms for peer-to-peer discussions and so forth with our gastroenterologists. So what do these guidelines accomplish? Well, from a provider standpoint, they can help educate physicians on what the evidence suggests is the correct approach to a particular problem. In this case, reflux. And perhaps some will incorporate them into their practices. From a patient standpoint, they help to ensure that the right procedure is performed at the right time and saves a percentage of them from downstream morbidity that may accompany a low-yield procedure. And from a cost standpoint, adoption of the guidelines can help redirect funds from common low-yield procedures and their attendant expenses to those areas where the impact on healthcare can be considerably more meaningful. For example, a very robust colon cancer screening program. And finally, for the last slide, these are just, for completeness sake, some of the references that we used for our presentation. So I'd like to now turn to our panelists. All of them work with eviCore. Some of them also maintain active clinical practice. First up will be Dr. Joe Weiss. Dr. Weiss, would you like to give us a bit of your experience? Oh, we don't hear you, Joe. Can you mute your
All right.
unmute? There you go.
Thank you so much. Hello, everybody, and welcome to the program. And for me, it's a real joy and pleasure to share my experience. I've been with eviCore for about a year now, but I consider myself chronologically gifted. I've had about 40 years of experience in gastroenterology, and a number of those years on faculty, and I enjoy teaching medical students, interns, residents, fellows, and colleagues by doing a lot of CME programs as well. And one of the things I've learned after 40 years in gastroenterology is that change is to be expected. It happens, and it will continue to happen. And the changes, the advances are dramatic. In our field, the advances in technology, the advances in knowledge continue. In fact, as we're looking today at the devastating COVID-19 pandemic, look how fast things have changed even in the management of COVID over the last 12 months. Moving from a novel, devastating pandemic virus to mRNA vaccines, different approaches in therapy, change is ubiquitous and we have to accept that. I've also learned after all these decades in medicine that we all have beliefs, and beliefs are fine. I respect beliefs, but it's embarrassing to me how many of my beliefs have been proven wrong over the years. I recall the first day of medical school over 40 years ago where our dean shared something that he had read about from a dean at Harvard years before. The dean introduced the class to the faculty and said, we're going to teach you everything we know about medicine over the next 4 years, but there are two problems you really need to know about. Problem number one, half of what we teach you will be proven wrong in the years to come. And that's not the big problem. The big problem is we don't know which half is wrong. So in my own experience, from the annual surveillance of Barretts to the annual surveillance of the colon for colon polyps, we have made tremendous progress. We have now not just the belief this is the right thing to do, but evidence-based knowledge, which documents what is the appropriate care, what is the appropriate level of frequency. And you can expect that these guidelines will change as well as technology evolves, and perhaps rather than colonoscopy or stool-based tests, we're expecting blood-based tests to become available to screen for colorectal cancer. If you don't mind, I'd like to share my own personal experience, and Dr. Scheinert mentioned some of the concerns we have about overutilization, the number of endoscopic examinations, the EGDs, that do not meet with current standards of guidelines. In my own experience, I underwent, in fact, I have performed thousands of colonoscopies. I have been on the receiving end of 3 of them for colorectal cancer screening. And I think that's a great idea, but perhaps we're overutilizing, even in that aspect, how often we have performed the procedures. One of the examples I want to share is when I was going for my colonoscopy, my gastroenterologist suggested, you know, you have reflux on occasion. Let's take a look, make sure you don't have Barrett's. That makes sense. Let's do a turnaround procedure. Well, I had the EGD at the same time. Procedure went fine, no complication there. They did take a biopsy, a little bit of gastritis. I ended up with Helicobacter pylori. I consider that an occupational hazard as a gastroenterologist. And I was placed on antibiotics. And of course, as luck would have it for me, I was one of 300 people that year in the United States who came down with severe Stevens-Johnson syndrome. I was hospitalized, 8 days in hospital. Now, this is an unexpected complication, and actually it has a fairly high mortality rate, about 20 to 30%, and there is no known effective therapy. Although my physicians were well-meaning, I nearly died in hospital. And if it wasn't for my own personal gynecologist, happens to be my wife, Nancy, who identified that I was going to pulmonary edema from fluid overload, I may not have made it. So medicine, as much as we want to be helpful and beneficial, has risk, and there is expense, and we want to do the right thing. I am convinced that all of us in medicine really want to take care of our patients and do the right thing for them. So to provide the highest level of quality, to avoid excess utilization, to avoid the potential complications, and although they are infrequent, they do occur with regularity, adhering to the guidelines is a real advance. The guidelines also allow us to summarize the medical literature for our colleagues, to provide them with a summary, because it is impossible to keep up. There are over 5,000 publications every single day with advances in the biomedical sciences. So when it comes down to beliefs, again, not all beliefs are correct. The evidence-based, knowledge-based in truth is really helpful. But I also like to comment, there's a distinction between knowledge, having data, information, and wisdom. And after all these decades in gastroenterology, I think I've acquired some wisdom from mentors and others. And there's a great quote from Albert Einstein. Knowledge is knowing that the street you're about to cross is a one-way street. That's knowledge. That's important. More important is wisdom, to look both directions anyhow when you're crossing the street, just to make sure. So when it comes to the guidelines, I found them to be extraordinarily helpful. When I share them with colleagues on peer-to-peer calls, nearly uniformly, they all embrace it. They welcome the new information if it is new to them. They understand the value. And when it comes down to it, we are here as an ally, as an advocate. We all want to do what's right for the patient, to give them the highest quality of care. We have a responsibility to our member patients, and we take that very seriously. And we also take seriously our responsibility to our colleagues and providers. Our responsibilities to the insurers and the payers to make sure that everything is maintained on a cost-effective level. So I'd like to welcome and share with you, we are all here to be of assistance to you. If we can help in any way, we do want to help. We do like approving procedures. We don't want to deny them. If you can provide us with the indications, the reason for the study, that they meet the guidelines, you are all set. In fact, you won't even hear from us. But if need be, we are available and would really enjoy helping you. So again, thank you for your time. Thank you.
Thanks, Joe, very much. Jaya, I turn to you for your experience.
Thank you, Dr. Scheiner and Dr. Weiss. One of the things that has happened in the past 10 years in the field of gastroenterology is that we have put a tremendous amount of effort into answering the question, how often does this patient need an endoscopy? And that is true with regard to very serious findings on the initial endoscopy, such as malignancy, as well as findings that fall somewhere on the spectrum between completely benign and somewhat worrisome. The evidence related to follow-up intervals has become granular in a way it hasn't been before, and has allowed us to risk stratify patients who need more frequent endoscopy and those who can just be followed clinically. If you ask most gastroenterologists when to perform a follow-up endoscopy in a patient with malignancy, you'll get a consistent answer. That becomes more difficult when you talk about findings such as gastric metaplasia, hyperplastic gastric polyps, and atrophic gastritis, to give some examples. In these settings, sometimes the information, as Dr. Weiss suggested, is harder to access, or it hasn't been compiled in a way that eviCore has done. And being able to provide this information on a peer-to-peer not only allows the provider to be able to comply with evidence-based intervals for that particular patient, but also allows, in the setting of low-risk patients, allows that provider to communicate effectively and confidently to that patient, explain to them that the findings are not worrisome. And this, I think, reduces, and I found this in my own practice, reduces both patient and provider anxiety that sometimes can drive too frequent surveillance intervals and add unnecessary risk. So I think that just as Dr. Weiss was suggesting, this is a very rewarding part of the work we do to be able to interact with our peers and provide that education and really engage with them on how that applies to their individual clinical circumstance.
Thanks very much. Tauhid, if you could share some of your thoughts.
Yes, thank you, Dr. Scheiner. Thank you, Dr. Weiss and Dr. Agarwal. I've been with eviCore for about a year, and I'm very excited and grateful to be part of this team, to be honest with you. So as an interventional GI doc, it's very chaotic in the clinic and procedural space. And so to embody Dr. Scheiner's slide, I just had a peer-to-peer a few weeks ago regarding a case of a 60-year-old individual that was undergoing annual upper endoscopies for Barrett's esophagus without any type of dysplasia. So it was a very informative peer-to-peer where kind of reminded the providing physician that, based on the guidelines, it wasn't necessary. And he was reminded of that, and just, we shared the experience of just, there's just too much information and too much bombardment, during an office setting sometimes to keep track of things. So it really was helpful for the patient to save time and money, and obviously to follow the guidelines save the insurers the money for the case as well when it was unnecessary. So I think we're all trying to do good, and I think this is a very helpful program, to be honest.
Thanks very much. Let me throw out some questions that you might chime in on. What do you find are some of the common reasons that a case may be denied? That's a common question that we have. Joe, would you like to answer to that?
I would be happy to. In my experience, one of the most common reasons is that the records were incomplete. We did not receive information, perhaps not even any information, about the history, the physical, the indications, why the procedure has been requested. Without that basic information, we cannot approve a request. It gets turned around, sent back to the physician provider's office, asking for supportive information. It's really an exceptional burden on their practices to have to do this twice. I would strongly encourage those who are requesting services to please make sure that the records that are submitted support the request, the indications, the background. It doesn't take much. It can be a single page of information, gives us all the information we need to approve. And by the way, it won't even come to us as a peer-to-peer discussion or a need for conversation if the records are submitted. It's automated. You will be getting an approval without us seeing it. If the indications meet the guidelines, it will get approved. So I would encourage everyone to please make sure that the submittal is complete. If it's not complete, it will come back. You will eventually complete the submittal. Do it the first time around. Save a lot of time and energy and effort. And that's the most common reason for the decline.
Do you think that relates to how the information is initially supplied, who is supplying that information, and so forth?
Absolutely, without a doubt. Because when we have a peer-to-peer discussion, and I enjoy talking with colleagues, I don't want to discourage that. In a way, I'm being a little bit selfish. Don't send in the records. I like talking to you guys, but when it comes down to it, if you send in the records, the complete records, it will be approved. What typically happens, I suspect, is the physician makes a note, this is what they would like to do, and their staff takes it from there. And the medical staff, the front office, the clerk, whoever it may be, may not realize that that information is required, number one. If information is required, they may send the wrong information. We get all sorts of registration forms, and as you're suggesting, we can get dozens of pages on extraneous, irrelevant information to the request for an EGD. It doesn't take much effort. If you can make sure that the clear indications, and they will meet the guidelines, if you know what the guidelines are, and again, they are readily accessible to you. For me, I enjoy reading the guidelines. I learn a lot when I'm looking at other specialties and reading their guidelines. It is all evidence-based. It makes absolute sense, very logical, very clearly written. It's all spelled out for you. And with that information submitted, it's real easy. It moves very, very quickly.
Thanks very much. Jaya, do you think that you have changed some providers' ways of practice? Do they seem to adopt what you discuss with them in the course of a peer-to-peer?
I think so. I think as you were mentioning, and as Dr. Weiss was mentioning, and also Dr. Ghazi, I think this in practice, there is a time is very valuable, and so when somebody provides you with information that would otherwise require a considerable effort to have to seek out and find on your own, I think people are generally appreciative. I think the other part of the information that we often provide on the peer-to-peers is sometimes the provider doesn't know that the patient has just had the procedure or has recently had the procedure. Sometimes patients will see more than one provider in a different system, and so providing that information, letting the provider know that the patient appears to have had a recently approved procedure that is or very similar to the one that they are ordering, allows them to then go back and find the results of that procedure and speak to the patient a little bit more and obtain a little bit more history. And I think everybody benefits from that. So the peer-to-peers, I think, have been very rewarding on both levels.
Thanks very much. Tauhid, anything to answer for that?
Yeah, I mean, I agree with all Dr. Weiss and Dr. Agarwal has said. And I mean, for my own personal practice, let alone for other providers, I've used the guidelines to, in fact, improve my own practice measures and metrics. So I'm very appreciative for that it's improved, my own practice as well. And I think that the peer-to-peers, it's a certain mindset. So one of the things about eviCore is that we're here to help. We're not here just to deny. We're here to kind of, really enforce the best patient care. And that's the kind of attitude we've taken with our peer-to-peers. And I think that's why we're embraced that way.
Thanks. And let me ask this of all of you, has anything in particular stood out in the context of your peer-to-peer discussions? Joe?
I would suggest that it's a two-way street. I think we all enjoy learning. At least for me, I still love learning. And to share information with colleagues and have discussion about it is, for me, a great part of the work that I do at eviCore. I really enjoy the peer-to-peers. I also enjoy being a student, and as we have divisional discussions and meetings about the guidelines and always updating, always enhancing, we're always reading the literature, I enjoy it immensely. And when I share with colleagues our experience, I can't tell you how many times they are somewhat envious that I get to be a student and learn and keep up with the data when they are swamped, not only clinically, but how can I possibly keep up with all this information? And what I really appreciate is their expression of gratitude that we are doing it for them. We are keeping the guidelines updated. We are continuously reviewing the literature, bringing information to them, sharing with them. And I learn from them, hopefully, as they learn from me. It's a two-way street. So we're all in this together. We're all motivated to really improve the quality of care, to avoid excess, wasteful overutilization. That doesn't benefit anyone. And if we can bring the level of care to a higher state, we all benefit.
Yeah, I agree. And actually, you touched on an important point, which is how we actually make these guidelines. How do we do it? And I could speak to that for a second. As I mentioned, we have 12 board-certified gastroenterologists. We review these guidelines on a constant basis. We are always on the lookout for the latest literature, most particularly any specialty society guideline that should come out. And we seek to make sure that we adopt what a specialty society tells us we should be doing. We review the literature. Individual gastroenterologists within our group take on assignments and review the literature, and then it is presented to all of us, and we all gather together very frequently. We discuss the latest literature, we discuss how and we might implement it and where it should fit into the guidelines, and then there's agreement between all of us after a pretty good as you know, as you can remember, how we vet the literature and have our discussions, and then finally arrive at a consensus amongst the 12 of us of how the guideline could best interpret the literature that is being presented. And this is a very, very important part of the production of the guideline. So I just wanted to touch base with that. Everyone present here today has participated in that guideline creation. Some of our audience are primary care docs. Tauhid, do you have any words of wisdom for them?
I think that it's a very academic, measured guideline that we've kind of enforced and are promoting, and I think this is just helpful for everyone to have a kind of clear-cut approach to the GI program.
Thanks. Jaya?
I wanted to add is that may not be known is that these peer-to-peers are often very quick. We prepare in advance, and we know these guidelines incredibly well because of the process that we went through to create them, and typically, we will lead the provider to the missing piece of information, for example, and say it looks like the reviewers here were just looking to see if the patient had some conservative management, or the reviewers were just looking to see if this prior authorization had expired before being used. And sometimes these peer-to-peers really just last minutes, even the ones where we do review some of the updated guidelines. And our goal is really to really help the provider and take as little of their time as possible.
Thanks. And I think that process in which we create the guidelines really empowers the gastroenterologist. I'm sure that you would agree with that, because we all review the literature together. We're all steeped in the literature. We all know what the actual background of the guideline is. And so in the context of a peer-to-peer, we can refer to the actual literature from which the guideline was created. So, for example, the American College of Gastroenterology has a guideline on this exact topic, and what that says is, and so we're able to talk on an intellectual level with good background information, and I think that that's very important for us. Are there any other words of wisdom? Joe, I'll start with you and go through all three.
One thing we really haven't touched on, and I think it's a misconception from many, that our focus really is on cost containment. It's really not. Our focus is on quality. That's what we're really motivated and interested in. If we can reduce expenditures by avoiding unnecessary procedures, yes, that's appropriate. And by the way, I had mentioned that I had undergone an EGD and colonoscopy as part of my earlier comments. I had never seen a bill for services until I had that, and I didn't realize how many additional expenses there are besides the professional fee. So ended up with anesthesia services, pathology services, the outpatient endoscopy service. And when we think of it as gastroenterologists or as primary care physicians, well, here's the cost of the EGD or the cost of the colonoscopy. We think of the professional fee. It is much, much more than that. You talk about site of service, the differential between expenses there. So that's another area, but again, I do want to focus and comment that really we are primarily concerned quality, improving the quality of care for everyone. The cost is there, but that's not part of our formula or of our discussion about whether this procedure should be approved or not.
Thanks. Jaya?
I also agree with everything that has been said. In terms, I want to emphasize the point about the staff and sending the information. The more information we have, the less provider time is involved. And I also am a part of a busy practice, and taking a moment to train the office staff in terms of providing them with a checklist of materials that need to be sent when a prior authorization is being created, I think can go a long way to sort of reducing any provider burden of time, because that is really the goal. The goal is to help guide medicine into sort of an evidence-based state without creating any more burden on the system.
Thank you. Tahid?
Yeah, I concur with everyone's statements. I think the focus that we have is a more academic approach and an efficient approach based on the literature, and that's really what we stress, and so that's why this is so effective.
Thanks very much. I have just a few final words from myself. We've now had over a year's worth of actual practical experience running the program. And in fact, it's found to be very successful. In view of this success on the calendar for this year will be the expansion of the EGD program to new clients, the rollout of a robust colorectal cancer screening outreach program, as well as an endoscopy site of care redirection program when appropriate and when there are quality ambulatory surgery centers available. It is important to realize that endoscopy in low-risk patients is often performed in a hospital outpatient department. This can occur for various reasons, including convenience for the physician, how a physician is employed, for example, if the practice is owned by a hospital system, and so forth. But this is a significant cost concern. Site of care cost savings to the healthcare system are actually huge. Currently, U.S. healthcare costs are reduced by more than $38 billion per year due to the availability of ambulatory surgery centers. And what most people do not realize is that $5 billion of that $38 billion accrues directly to the patient through lower deductible and co-insurance payments. And these numbers are based on just the current level of 48 to 50% of procedures which can be performed in an ASC actually being performed in an ASC. So there's significant and important room for savings in this area. So I just wanted to bring that up. That's some of the near future for where we're going in terms of eviCore's utilization program with regards to endoscopy. I think, Bill, that's it for today. Let me turn it back to you.
Thank you again, Dr. Scheinert, and our clinical panelists for sharing your expert knowledge with us today. And thank you all for your attendance. This webinar was recorded and will be available on demand by visiting eviCore.com. Please remember to register for our upcoming webinars. You will receive an email invitation with the opportunity to do so. This concludes our webinar, and I hope that you all have a wonderful rest of the day.
Thank you all very much.